Good morning, everyone. I am Kamal Narayan, CEO of Integrated Health and Wellbeing Council, India's premier institution for health advocacy, awareness, and behavior change communication. I welcome you all to the second edition of India Immunization Summit, an IHW Council initiative to commemorate the global campaign of World Immunization Week, observed by the World Health Organization every year in the last week of April. This observance aims to create awareness of the significance of vaccination for protecting people and to motivate them to get vaccinated to prevent deadly infections. During the pandemic, the world made a Herculean leapfrog in COVID vaccine discovery and its administration, but witnessed a massive disruption in routine immunization, especially for those with the most dire need of it, and exposing many to deadly preventable diseases. Now that COVID is no longer a pressing emergency for the health systems, the time has come to accelerate the immunization process, thus ensuring that we can bridge the critical gap. And this is precisely why the theme of this World Immunization Week has aptly been picked up as the big catch-up. In the space of vaccines and immunization, India has some envious feathers to its hat. Even before COVID-19, India was the largest producer of vaccines, with 60% of the world's vaccines coming from it. COVID only strengthened our position further. We not only came up with our own indigenous vaccine in record time, but also produced the big chunk of over 12 billion doses of COVID vaccines deployed globally. More importantly, we also achieved the tremendous feat of administering over 2.2 billion doses to our people. With our capability to large-scale immunization, we could also eradicate polio, smallpox, and maternal and neonatal tetanus in the past. The government's universal immunization program and initiatives like Mission Indradhanush aimed at enhancing coverage and reach has made remarkable progress regarding child immunization and hopes to target nearly 227 million newborns for annual immunization. The public immunization scheme have already included necessary vaccines like pneumococcal conjugate vaccine or rotavirus vaccine. In a much awaited step, the government has also announced its plan to roll out the HPV vaccine among young girls to protect them against cervical cancer. However, as seen during the COVID-19 pandemic, adult vaccination is an also essential aspect of public health ecosystem. It needs to be advocated at the policy and societal level. Despite vast improvements in childhood vaccination coverage in India, adult vaccination coverage is negligible despite the availability of vaccines to prevent more than 20 life-threatening diseases. Although the acute burden of vaccine preventable diseases among Indian adults is unknown, adults are particularly vulnerable during outbreaks due to lack of immunization, waning immunity, age-related factors, and epidemiological shift. We can create relevant awareness on the negated aspect of life course immunization and identify and address the gap in it from a public policy perspective. So let me introduce and welcome today's esteemed speakers who have joined us for this session. We will be joined by Professor Dr. Y.K. Gupta, President AIIMS Bhopal. Dr. Gupta has an experience of almost 4 decades and led several key departments and committees at AIIMS New Delhi. Before taking the charge as the President of AIIMS Bhopal, Dr. Gupta held the position of Head of Department of HOD of Pharmacology and Pharmacovigilance at the Delhi headquarters. We are also being joined by Dr. Pradeep Haldar. Dr. Haldar is the Honorary Strategic Advisor at John Snow India. He has led many programs and initiatives on immunization as part of National Health Mission. We are joined by Dr. Arindam Roy, India Country Lead, New Vaccines and Immunization Systems, Bill and Melinda Gates Foundation, and also by Dr. Prashanta Kumar Roy, Technical Officer of Intensification of Routine Immunization as WHO Country Office in New Delhi. Dr. Roy has extensively worked in programs such as eradication of polio and elimination of measles rubella. We are also joined by Mr. Abhimanyu Saxena, Senior National Program Manager of Co-Win and E-Win Health System Strengthening at UNDP India. He has been associated as expert on immunization with organizations like National Institute of Health and Family Welfare and UNICEF. We will be joined by Mr. Vishwanath Swarup, CEO of India Business at Bharat Serums and Vaccines Limited. He has been leading many important projects as BSVL, focusing on affordable healthcare with larger goal of creating a health ecosystem to benefit all. And last but not the least, Mr. Sarad Goswami, who has joined us from Pfizer India. He's a Senior Director, Global Policy and Public Affairs at Pfizer India. Mr. Goswami is an ace public policy advocacy and communication professional with extensive experience of helping several corporates, not-for-profits, and state governments in this regard. So welcome all our esteemed speakers who have joined us today on the first session of India Immunization Summit. And we all would also like to take this opportunity to thank our partner in this program, Pfizer and BSVL, for their kind support to make this program happen. Let me begin with Dr. Pradeep Haldar. Before Dr. Y.K. Gupta joins, I wanted to start with him to understand a little bit more about what has been the great success of Indian immunization program so far. So let me go to Dr. Haldar. Dr. Haldar, after the successful child immunization, I have outlined a bit of it, but I would like to understand from you also, how do you see the success of Indian immunization program so far, and where do you see the big hits and big misses in this?
Yes, what I would say that when you're looking at the country's immunization program, which started in 1985 as Universal Immunization Program, that's the period, and by 1990 the country was able to expand the immunization program nationwide. But then two things that happened. One was that we needed to improve the coverage, and also we needed to increase the basket of choice for vaccines, which are there at the door. So we had looked at as a two-pronged activities. One was where we were strengthening the routine immunization, as well as we were also implementing the campaign approach from 2013-14. That's where we were doing the mission and the Dharmas as a catch-up to those who have missed out routine vaccinations. Because of this two-pronged activities, we have been seeing that there has been an improvement in the immunization coverage. And in fact, even during the COVID period, we have only seen about 3 to 4%, 5% dip in antigen-wise coverage. Globally, I think so. When we look at different countries, there are countries which were able to come back and improve on their pre-COVID period. There are countries which was actually dipped and slided heavily, and countries like India, which was only the slight slump was there, but was able to catch up. Now, the question was that in last 4 or 5 years, also while we were trying to strengthen routine immunization, we were also looking at adding, I would say, almost 6 to 7 new vaccines, like pneumococcal vaccine, like rotavirus vaccines, like switching from TT to TD vaccines, MR vaccines, so on and so forth. So there has been a host of vaccines which also got added into the immunization program, and therefore the program became very, very vast, covering large. We also, while we were looking at adding vaccines, we are looking at strengthening immunization coverage. We had two big milestones. One was polio eradication. Last case was in 2011. 13 January 2011 was last case, and 2014 was when we were certified as polio-free. And similarly, the maternal and neonatal tetanus elimination was being given to India also by the WHO. So if you look at it, that we were also looking at different milestones. And yes, during the COVID period, we were also I would say looking at the ways of improving not only the routine immunization, but also reaching to the entire population for vaccinations. And that's where more than 2 billion populations has been vaccinated in the program. And we have used the digital platform. Adult vaccination is always going to be a challenge, and specifically the platforms will be always a challenge. Go from my side.
Thank you so much, Dr. Haldar. Absolutely, a lot of commendable progress has been seen. As you highlighted that, almost 5-6 new vaccines are being introduced, and it has all happened while also increasing the access and coverage of vaccines to the maximum part of the country. And at the same time, also the over 2.2 billion doses of COVID-19. Let me go to Dr. Prasant Kumar Roy from WHO. Dr. Roy, as you know, while we look at the theme of this, immunization week, the big catch up, and which is primarily aimed at addressing those gaps which have kind of creeped in during the COVID-19 focus of the health systems across the country, across the world. But when we look at that, the big catch up, what we have, kind of left in between, the adult immunization is one big, I think, step where many of the countries and especially India as well has been lacking. I would like to understand from the health burden point of view, how do you see from WHO as kind of perspective, how do you see the burden of health or the burden of diseases on a country can be if we continue to kind of ignore or not being able to include adult immunization in our routine immunization process?
Yeah, thank you for giving me the opportunity. Adult, as Dr. Haldar was mentioning, he had been leading the program. So adult immunization has been and is a challenge in comparison to childhood immunization. And the stand taken by the country is also to see the priority, which are the priority. And if we want to reduce the neonatal mortality or child death, childhood immunization is important. Now, the country has the experience of adulthood vaccination through this COVID immunization campaign. There were many challenges apart from even the ongoing pandemic at then. I mean, we have been monitoring, and if we look into the data of around 1 lakh people monitored for COVID vaccination uptake, we find that around 7% were non-immunized, and of 11% who were partially immunized, means had taken one dose but not taken the subsequent 1 or 2 subsequent doses. We see that the awareness gap, 18% of those partially immunized or non-immunized, 18% who could not take the vaccine were because of awareness gap, and obviously then follows the AFI and apprehension. Now, if you see the rural-urban divide also, which may prompt you that maybe these are different dynamics, but again, the pattern is very similar. I mean, 21% of urban non-immunized or partially immunized was because of awareness gap, whereas in rural it was just 25%. So 21, 25 more or less the same. Similarly with AFI apprehension, it was 20%, 19%. So rural-urban immunization again, but yes, coming to the point, vaccination does helps, and it has an impact on overall health, public health and disease prevention. For example, we take the example from elimination of polio in 2011, it was mainly due to vaccination. So also you have mentioned about neonatal tetanus, which has come down. We are also seeing, I mean, there was 95% drop in diphtheria cases since the diphtheria vaccine was introduced into the system in 1978. And very soon, take my words, we are going to have the measles rubella elimination also. So it does has an impact on the disease, but again, we have to see the disease burden as well as the priority of the national government. Over from my side, thank you.
Thank you so much, Dr. Prasanta. Yeah, absolutely. Again, as you reiterated the fact that we have made a progress, and that's really commendable. And I think we, as a country and as a health advocate, we all feel proud that what we have achieved so far, and then the kind of focus and attention has gone in achieving these milestones. But at the same time, when you look at the bigger picture, you do feel that I think this is the right time to kind of move to the life course immunization or something which is also creating a major kind of disease burden or maybe mortality in the country. Some of the figures, as if we look at that, almost 7% of Indian population is over above 65 years of age. Now that is the kind of age where you are recommending, and almost every medical association, or including even the government of India, has started recommending that there are certain vaccines which especially the flu pneumococcal kind of vaccines which should start for the adults also, and especially those at the elderly age. But at the same time, we are not able to kind of integrate the same in our public health system or the public immunization processes. I agree. I'm sure there would be challenges, as you have highlighted and Dr. Haldar also highlighted. Let me go to Dr. Arindam Roy from Bill and Melinda Gates Foundation. Dr. Roy, how do you look at the adult immunization, kind of status and coverage in India? Though it is not a part of public immunization system, but at the same time, there are kind of several efforts being made by the private sector, by the kind of healthcare practitioners, making people aware about it. How do you see that at the current state, and how we kind of move from it?
Yeah, thanks, Kamal, for this very pertinent question. But at the very outset, I just like to thank the organizers, ISW Council, for giving me this opportunity to sit among the galaxy of experts to participate in your inaugural session. Pre-COVID, there has been a report by a group of researchers from Johns Hopkins University who actually looked at the archetypes of the immunization program in 34 countries. Now, they actually identified 4 archetypes. Within that, the 4th archetype was, which is child-focused and cost-sensitive. And that's the archetype which fits India in. Along with India, of course, there are other countries like Russia, Peru, Philippines, and Switzerland. Now, obviously, as Dr. Haldar has also mentioned, and you have highlighted, that our immunization program's primary objective was to provide universal free vaccines for the children, to reduce under 5 morbidity and mortality against the most severe vaccine preventable diseases. And India has come a long way, and in terms of achieving vaccine access, coverage, equity, introduction of new vaccines, production of new vaccines and technologies. And India is now playing a pivotal role for the rest of the world, actually, to exporting both the hardware and the softwares, and the collective lessons from implementing the largest immunization program in the world. Now, while you transition from a child-focused vaccination to a more life course immunization strategy, I don't like to skip the adolescent group in between to go to the straightway to the adults, because you need to take a continuum of care approach. And India is actually rightly doing so. If you look at, and they are doing in a very evidence-informed way, and India has a very strong, the fundamental pillars for a very functioning immunization system. On one side, there is very competent, NITAG, the National Immunization Technical Advisory Group, who actually deliberate on the entire disease burden, efficacy, safety, effectiveness, compatibility of all the vaccine programs before actually going for recommendations, which we need for that kind of a mechanism in this large country. On the other hand, there is a very strong regulatory body, DCGI, who actually look at all the evidence and has helped enormously for growth of the domestic vaccine manufacturing sector. And we also have a very competent and able, software industry. India is actually leading. Why I'm mentioning all of these? Because all these fundamental elements are already there. And now when you are graduating from a child focus to expanding into, more life course trajectory, India is bringing in, you have seen that India has switched from tetanus vaccine to the TD vaccines in the adolescent groups and also for the maternal immunization. And then the COVID vaccine, as you have already mentioned, India leapfrogged on many fronts. Right now, we are having the largest name-based immunization registry in the world, COVID, and which India has made a global public good under the able leadership of our Prime Minister. And during this G20 presidency year, I like to highlight that many of these lessons would become a kind of a treasure house for other countries to eliminate. And this Prashant has already mentioned, I think the COVID, training resources, the implementation learnings, WHO has played a critical role to actually disseminate India learnings to the other countries so that they can also get benefited from it. You have mentioned about EVIN. I don't like to steal the thunder from Abhimanyu, who is leading the EVIN and UIN part. Dr. Haldar has been instrumental through the last decade, actually, in many of these developments. So, with all of these, now India is thinking about the vaccines which are for adolescent groups as well. Prashant has mentioned about the MR elimination. Right now, India is targeting to MR elimination probably as early as 2026. And that if that can be achieved, that would be a huge, huge success. And that will be achievable through wide age range campaigns, probably up to coverage of 15-year-olds, which actually touching in the adolescent groups. Similarly, there is already NTAGI has recommended, and we know that government has accepted and proceeding forward on other vaccines for the adolescent groups, including HPV vaccine, typhoid conjugate vaccine. So we are going there. Now on the adolescent vaccines, there are, I think, if time permits, we'll come back to more specific or vaccine specific discussions. But I just like to say that, as Dr. Haldar has also mentioned, India offers completely free universal access for the childhood vaccine. And that has enabled the population at large to get that coverage and ensured access. Now, in order to offer that kind of a free vaccination for adults in 1.3 billion population country, it's a matter of priority setting. Of course, you cannot do it universally. So how do you set those priorities? So there has to be some kind of a framework, and now there is the International Council of Adult Immunization who has already laid a roadmap. There is some work in India which has also been done. There has also been a study which is longitudinal aging study, and Odisha actually has come out with a kind of a framework. So, and there are already lessons available from, in piecemeal. I'm not saying that they were systematically adult immunization, but there are lessons for adult immunization, say polio immunization or the meningitis immunization for Hodge pilgrims or the yellow fever vaccination for the travelers. These are the examples where adult vaccination actually takes place in India. You can say this is focal efforts, and these are under the obligation of international health regulation. But these provide a kind of a regulatory systematic framework to look at. And I'm just saying, while COVID provides probably the largest immediate lessons, there are other lessons pre and para-COVID, which also we can curate and can actually formulate to have which are the priority groups that the government should consider while going for the adult immunization. And there are two aspects of it. You can have some vaccines offered through a national program, but that doesn't necessarily mean that all the vaccines have to be offered free. There are other mechanisms, and if time permits, we can come back, because all over the world, funding for adult immunization has been cited as one of the chief constraints for the adult immunization coverage. Now, should these be the elderly with comorbidities? Should there be high-risk occupational groups? Should there be, say, maternal immunization priorities? I just quickly like to mention that after successful ramp up of coverage of pentavalent vaccine to say more than 90%, measles elimination goal is just in horizon. And the pneumococcal vaccine, as Dr. Haldar mentioned, is scaled up all across the country, and actually coverage is increasing. The residual pneumonia burden comes from RSV, respiratory syncytial virus. And there are actually effective vaccines in the horizon. And there are India's Lancet study is already showing there is a high disease burden, both in terms of morbidity and mortality. If you look at India, there are recent studies, even in rural areas in Maharashtra, which is showing that every one hospitalized death due to RSV, there are 13 community deaths coming from RSV. And there is kind of 23 to 50 RSV hospitalization per 1,000 child years. So, there is a sizable disease burden. And I'm sure that there are, expert groups within NITAG and other policy bodies which are looking at all this data. There is a modeling group who has been invited by NITAG actually to discuss on RSV vaccines, potential to save much more lives. And these are the kind of priorities. So I just like to make a distinction here. So when you say adult immunization, it's not necessarily that by immunizing adults, you are just protecting the adults. RSV vaccine is a classical example where by immunizing the mothers, you will be actually protecting the neonates, the babies, they are particularly under 6, and you can overall reduce the under 5 mortality. So we should look at the entire adult immunization spectrum from both these perspectives, that adult vaccines for the high-risk adult individuals, but at the same time, adult vaccines as a channel to protect and reduce further disease burden in the most vulnerable, which are the children. So anyway, I don't like to take much more time. Maybe we will revisit some of these topics if time permits. Thank you.
Well, thank you, Dr. Roy. I think you have given a very balanced view on that, looking at that what all has been achieved and how we are progressing, also transiting from child-focused immunization system to how we are now kind of taking the continuum of care approach by involving the adolescent. And I think the very well example is definitely of the government's now plan to roll out the cervical cancer vaccine, the HPV vaccine, as you mentioned, and also the MR1. Let me, before I go to the more technicality also of what all is needed to, kind of ensure that we are able to include the adult immunization, and through adult immunization, kind of protecting all age group, also including the kind of, the newborn, as you mentioned. Let me go to Mr. Sarath Goswami. Mr. Goswami, you are seeing that the country is almost progressing in the right direction, getting, several milestones and kind of, ensuring that wherever, the priority areas are, we are kind of doing the right things at the right time. And COVID-19 vaccination shows, that one of the major example of it. How do you see that when it comes to the country's ongoing approach and progress towards taking the continuum of care approach, or, kind of involving adult vaccination, adolescent vaccination in this? From the policy point of view, where do you see that, what is the approach which you feel is the fit for the country, in terms of keeping in mind that we have to make the right priorities in our public health? It cannot be kind of a corporate, approach for everything. How do you see from the industry point of view, while you see that there are vaccines available, this can be kind of be a game changer in terms of reducing the mortalities, reducing the disease burden, and obviously, it being the most cost-effective approach towards public health, and ensuring that you are able to not only reduce the disease burden, but also give a much more healthier life for the citizens.
Thank you, Kamal. And it's really exciting that in the immunization week, you have picked up the topic of adult immunization, and seeing the kind of conversation that I see almost every week. It looks to me like we are really headed in the right direction. And so many conversations have now started on adult immunization. That's very, very heartening. I think the first thing I'll say is that given our COVID experience and the national immunization program experience, I just feel that in every possible way as a country, we are absolutely ready to bring in the adult immunization concept. I mean, the state of readiness is as high as it can ever be. I mean, just from the perspective of, let's start with attitude. Today, people like you and me and many of, the viewers who are watching this, we are familiar with the idea that folks like us of our age group, of our parents' age group, can roll up their sleeves and take a vaccine. If there is any positive that may have come out of the COVID crisis, it is this, that there is now awareness that vaccines are for adults as well. If you look at the COVID platform, if you look at the concept of prioritization basis age and comorbidities, if you look at cold chain penetration, how to administer vaccines to adults, all of these things we have experienced with the COVID vaccination program. So all the building blocks are in place. We know how to select a smaller target group because of the age group that they are in, or because they may have underlying comorbidities, because we did exactly that with the COVID vaccine program. So these concepts are in place, the experience is in place. I will obviously speak a little bit about pneumonia because that's something that we are very, very familiar with. But if you indulge me, here are a few stats. It's amongst the top 4 causes of mortality across the world. In fact, if you take off COVID, which is now not causing that much mortality, thank God for that, it is amongst the top 3, right after tuberculosis and hepatitis B. India has 23% of the world's burden of pneumonia. 20% of the patients who get pneumonia get hospitalized. Mortality is as much as 5% in OPD settings and 25% in ICU settings. Now we talk about readmission. 1 in every 5 patients of pneumonia get readmitted within 30 days for pneumonia again. 1 in 3 in 1 year, right? 40% get readmitted more than once a year. So we know that here is a disease where obviously there is a level of prioritization that's required. And credit to Dr. Haldar, under his watch and stewardship, India introduced pneumococcal conjugate vaccine for, in the pediatric setting. But here is the thing. If you look at the incidence of disease, populations above 65 age have the same incidence rate of pneumonia as populations under 1. And then the minute you cross that age group and go to higher age groups, the graph really goes up very steeply. So yes, we are protecting on the one side, but on the other side, where the vulnerability is exactly the same, if not more, we have a gap. We have adults and elderly who today are not protected. When you add comorbidities to it, you're looking at a 3 to 9 times higher risk. Things like cardiovascular disease, chronic lung disease, chronic kidney disease, people who are getting dialysis done, for example. So we know that this is perhaps the best approach. And I mean, obviously I speak of pneumonia, but I'm sure it's the same case with many vaccine preventable diseases. So to your question, in a large country like ours, how do we really start introducing adult immunization? And again, like I said earlier, we know how to do it because we did exactly that with the COVID vaccine. So we've got to look at age as perhaps the first factor. We've got to look at a few of the underlying comorbidities as the second filter. And then we need to start introducing adult vaccination for diseases which have the highest burden of morbidity and mortality. And I think that's the right way for us to start approaching this. I will take a few more minutes. And Dr. Roy spoke about awareness. Now, and also you spoke about how it's not necessary that the entire adult vaccination initiative has to be public funded. And I completely...
Saraj, if I may come back to you on the awareness point on the second round.
Yes, sure. So that's what I had to say on how we can actually start.
I would like to hear a little more in depth from you, because you being a communication professional as well, how do you look at it? So let me just take Vishwanath Swarup, who joins us from Bharat Serum and Vaccines. Vishwanath, as Mr. Goswami was highlighting, that if we need to start, or if we wish to start the adult immunization process, we know how we can exactly do it. And we have done it in the COVID-19 vaccination, campaign. So picking up the high risk categories of people first, and one of the high risk categories, as Dr. Arindam also mentioned by the time you had joined, that the pregnant women is one that high risk category. And while we are seeing that certain vaccinations have been done in that group, and we have seen that the almost the elimination of maternal tetanus and so on. But at the same time, the one which mentioned by Dr. Arindam about the RSV vaccine, or for that matter, the vaccine for the RH factors. How do you see enhancing at least this particular immunization, at least in this particular high risk group, which is anyways is in the focus of our ongoing immunization kind of process?
Sure. So thank you, Kamal. I think first of all, big congratulations to IHW. This is a very, very important topic for us as a country, right? And I think let's take a step back. We're really talking about now evolution of healthcare in India. Not too long ago, we were worried about the primary health infrastructure, etc., etc. Now, I think as the new India is developing, and I'm not making a political statement, I think we are really talking about preventive healthcare, and vaccination falls in that space. I think COVID vaccination has really, if you compare the certificate that we get, a digital certificate, to someone in the developed country, shows how far ahead we are in terms of technology and enablement, right? Now, having said that, I think the government has done a fantastic job. I think I would make a point on overarching how we go about it, and secondly about RH negative. The first point is, we can't have the government do everything for us, right? We need to be very, very clear. There are parts that the government can really intervene and service. Then there are parts where the private sector has to come in, and that's how this partnership has to work world over, and so in India. I think if you look at now with the COVID app, the Arogya Setu app, the Abha number coming in, right? I think there's enough health economics studies available which shows, prevention is better than final treatment, so to say, right? I think structurally, if the government can help us get these platforms attuned to the vaccination schedule and aligned with that, that's a big game changer. That's a reminder for people, right? I am a little bit on the neutral camp. I don't think the COVID vaccination has clearly shown that we can do it as a country. But the mindset shift, from my experience that I've seen, adult vaccination is still not top of mind in all adults, even well-to-do adults. It's not there. It was there when the scare was there, and now it's gone, right? So if we put it as part of that whole process, then there's a enablement from the government. Now, we cannot do everything all together, and we will need to take a little bit of a staggered or a graded approach on a high risk profile. High risk, of course, geriatric population, etc., etc. But I think pregnant women, and again, there was a point being made, I think Dr. Ray was making it, that adult vaccination just doesn't impact adults, it impacts the rest of the population as well. RH negative is a classic example, right? If you don't take, one of the anti-Ds, then during your pregnancy, there is a high risk that the child will have some sort of blood disorder, right? Now, how can the government enable it, right? We as BSV we were one of the leading players, and we have a worldwide patent. We export it to multiple countries, etc. I think we are working very closely with the government and around creating this awareness. And we don't have to do anything new. Digital is very, very fancy, very, very clearly the new India focus. But there's Bharat as well, and Bharat still listens to All India Radio, right? How do we use those platforms to actually drive awareness? So we are partnering with governments. 2 state governments have already agreed to kind of just say, if the lady is pregnant, how do you really manage that protocol? We are working at a CHC, PHC level, where the woman goes and tries to get some help to kind of partner with them and say, how do we, not just for Rh negative, do a complete test for the woman, just very simple tests, right? Blood pressure, etc., blood group. And I think that's the piece that, the government and the private sector have to work with. Then comes the procurement. I think now as a country, we are now clearly, in the world's top few economies. We cannot say that we don't have funds, and I don't think that is the case anymore. There is enough and more funds available for healthcare. It is just about prioritization, and I think that's where, if the government can prioritize procurement of these vaccines and dissemination through their infrastructure, which is a collateral benefit we got out of COVID, I think we are 80-90% there. And I think given where we are, that's a huge win for us.
Thank you, Vishwanath. And I'm sure, as you have highlighted that, there is the need of that realization among all age group, and especially in adults, that there is a need of a vaccination for them as well. Conventionally, we have been thinking that vaccination is only for the newborns, for young children. And I'm sure that after COVID-19, that mindset started coming in. But at the same time, as we are getting out of COVID, that mindset is also kind of disappearing. And we need to leverage on that thought process, that mindset, and ensure that we kind of take it as an opportunity to look at vaccines as an important tool for public health interventions. Let me go to Mr. Saxena, Abhimanyu Saxena from UNDP. Mr. Saxena, your organization and your the primary mandate involves that how we can ensure the equitable and timely access for immunization for kind of people who all in need of it. And I'm sure we have heard about the technology being a very important driver in this whole process. The India could achieve this 2.2 billion doses deployment of COVID-19 vaccine only because of its very, very robust the technology backbone. And as the other speakers also highlighted, your institution and you have been actively involved in the COVID even platforms. How do you see the same platforms kind of becoming an important backbone for rolling out adult immunization, and especially when you want to do it in a kind of priority groups first, and then kind of move on to universal at the right time?
Thank you so much, Dr. Kamal, and my congratulations to IHW Council for this event. It's a pleasure to share panel with esteemed guest and my mentors, including Dr. Haldar, Dr. Arindam. Now, talking about inclusion and ensuring equitable access, I think as previous speakers mentioned, that the key ingredient already exists. India is a self-procuring country. We are pharmacy to the world. The vaccines are there. We have solid institutions, including NTAGI and DCGI. The expert group is there. We have a very robust cold chain network in the country, especially at the periphery level. The COVID vaccination program shows that we have the capacity to maintain the cold chain and deliver till the last mile. For the demand side, we have a good cadre of the mobilizers, the ASHA workers, which is recognized globally. So all the building blocks and the key ingredients are in place for sure. Now, ensuring equitable access and ensuring that we leave no one behind. We have very good case studies already with COVID vaccination by registering more than 1.1 billion beneficiaries, tracking them. We have a good case study of vaccinating Hajj pilgrims, vaccinating pregnant women for TB. So with that, I think building the gap, bridging the gap between the demand side and the supply side with the digital health interventions like even and COVID will definitely help us to reach till the last mile. Now, when we talk about the supply side, in 2014, Dr. Haldar and Ministry of Health conceptualized that India can develop a digital platform to understand and track each and every vaccines. Where are the vaccines? Are they in adequate quantity based on the consumption of that particular catchment area of a primary health center and community health center? And are they stored in recommended temperature? Because it's being a biological product, it has a short shelf life. So we installed temperature loggers across all the vaccine storage centers, what we call as cold chain points. And we ensure that every cold chain handlers, more than 29,000, have the mobile application called Even to digitize the vaccine stock and the storage temperature. So Ministry of Health sitting here knows that what is the temperature and what is the stock of a vaccine right from Leh Ladakh till the remotest block of Andaman and Nicobar Island. So with this robust technologies, the supply side can be taken care of, not just in terms of visibility, but as previous speaker said, understanding the targets, the consumption of a particular catchment areas, and establishing the correct reorder level to understand that as and when if somebody is interested for vaccination and at the session site, we ensure that we have adequate vaccines to deliver. Now, coming to the other aspect of what we call as digital inventory or digital registry, and this was one of the game-changing decision. And when Dr. Haldar and Ministry of Health decided that we will have individualized digital tracking of beneficiaries for COVID vaccination, which means we have to register close to 1.1 billion beneficiaries, track their vaccination status, give them a digital vaccination certificate with a QR code, and send them SMS notifications when their next vaccination is due. Now, the same digital public good and the same open source technology can be leveraged when we are thinking about amplifying the adult vaccination. All we need to ensure is that there are 2-3 fundamental principles that the end users, our healthcare workers, should be comfortable in accessing this kind of digital health solutions. It should be as user friendly as possible. It should work in the adverse condition. There are many areas in the countries where we have we may not have infrastructure to use these digital health equipment. So in a very low resource setting with low network coverage, we should be able to use the solution aggressively. And of course, the inclusion. We have beneficiaries for which we can, who knows how to create their Aadhaar ID, who have Aadhaar card, and there are beneficiaries who may not have a valid photo ID, who are part of migratory population. How to ensure those, and how to ensure that every beneficiary is registered with a unique ID or linked to the Aadhaar is very important. So that will be a key component, that how we ensure that inclusion is all, just like we did in COVID. So I think in line of that, I think Ayushman Bharat Digital Health Mission has some very critical initiatives, like the Aadhaar ID. Every beneficiary should have a unique health ID, wherein everyone can access the information as and when required. The healthcare professional registry, that all healthcare worker can have a unique health ID, unique healthcare professional ID, and then HFR, all healthcare facilities, including private and public, are linked to that Ayushman Bharat digital health platform. So once this common directory and common database will be in use and everybody use the single source of information, I think then we will be able to amplify this up to a major extent, and we'll be able to do the needful as and when required. Yeah. So I'll stop here. And
thank you so much, Abhimanyu. I'm sure you have kind of very aptly highlighted the whole technical and logistic backbone which we have built to manage the supply chain of vaccines across the width and length of the country. And I think that on that capability, we shown or kind of we were able to manage the mammoth task of ensuring this massive COVID-19 immunization across the country. Let me go to Dr. Haldar. Now we are left with the 10 minutes for this session because the second session speakers have already started joining, I believe. So I'll request everyone to be little, kind of precise on the points, and we can, kind of take everyone on this round of questions. So let me go to Dr. Haldar. Dr. Haldar, what we heard so far from all our speakers that almost on every front, whether it is being, kind of production of vaccine, we are already producing for the whole world. While it may be, kind of the backbone, technology, logistics, supply chain, and even our track record. We have wonderfully kind of focused on women, kind of maternal and child immunization. We have been able to eliminate diseases. We have been able to eliminate, polio, kind of tetanus, and we are in the process of eliminating more diseases and COVID-19. And also highlighted that it is more of a, the matter of priority these days than, the actual economy and the funding associated with it. How do you see that? What are the roadblocks now to kind of roll out or adult immunization? I'm sure, to begin with, we can go for a specific, kind of high-risk groups, kind of pregnant women, people with comorbidities, and so on and so forth. But at the same time, I think once we start that, this also gives a message to the entire population, and for all those who can also afford to go for the vaccines, privately or out of pocket or on a private setting. But it is important is that do we put it in that priority? So where do you see, kind of a gap or a roadblocks in terms of moving towards that we involve adult immunization and a policy level, and also start rolling it out?
Yes, when we are looking at health as such, NHM in 2005 actually gave focus. It's not immunization, but it's entire health structure which has been the focus, building infrastructure, building maternal health, child health programs, etc. When you're looking at the vaccination program, also, I would say that you have a prioritization. So looking at that, where is the burden, where is the number, and then looking at and vaccinating the childhood, because I would say still there are a lot of vaccines in the childhood vaccination which still needs to be looked into. There are adolescent vaccines which are still needs to be introduced. So the task is not over. Whereas I would say when we are looking at the adult vaccination, high risk group, we don't really have an electronic records of high risk group. So when we were looking at the COVID vaccination and we initially wanted to prioritize on the high risk group, we were lost when we were saying 45 plus with comorbidity or 60 plus with comorbidity. Literally, I would say that you need a declaration of the individual saying that I am a hypertensive, I am a diabetes, so on and so forth. So you really don't have a registry of the people that you're looking at. Pregnancy is a very temporary part. Maybe that's a separate group where you can. But identifying high risk group and saying that doing a vaccination of a high risk group or a selected group will always be a challenge. So what is looking at is that when you're vaccinating the adults, there is vaccines available. Maybe you bring in more visibility of this thing. These are all been discussed at the National Technical Advisory Group, and that's where they always would be advising that where are our priorities for vaccination and what are the evidences. Over from my side.
Thank you so much, Dr. Haldar. And I'm sure, as you are saying that, we are anyways moving towards kind of adolescent vaccines, which are important as well. And at the same time, when you are saying that the identification of high risk group is going to be one of the challenge, but I believe with the new digital health records coming in, with the new kind of ABHA IDs coming in, and I'm sure that we will be able to identify that group as well quite soon in the future. Let me go to Dr. Prasanta Kumar. Dr. Prasanta, one of the kind of roadblock maybe in the mindset when we look into the policy for adult immunization apparently looks like the cost benefit dynamics. Many time, the cost of these vaccines being high, and at the same time the benefits not being very established, or for that matter what kind of age group they are being used. As you see that a post 65 years of age, the overall immunity is also kind of going down, and the response of the vaccines are not apparently that strong as you may see in the childhood. Is that one hurdle for both policymakers as well as the end users, or the people, that they do not look into adult vaccines so keenly? You are on mute, sir, I believe.
Yeah, sorry. Taking cue for what from Dr. Haldar as well as Arindam, cost benefit is one issue, but the main issue is you have to understand how these new vaccines are introduced, and what Dr. Haldar has mentioned, it is deliberated upon by a group of experts at NTAG. So where all these things, disease burden and then other factors are taken into account, and then a decision is made. Now, again, in continuation with what Dr. Arindam said, you have to see, earlier the focus, still the focus is childhood vaccination, but gradually it is expanding, and adolescents are coming into the net. There is what the continuum of vaccination. Obviously, there are discussions on life course vaccination, but again, it has to be very gradual, and it has to be decided by the group of experts. So who takes into all these factors into account? And believe me, understand, there is a system which is in place. Anything which is first discussed and decided upon can easily be rolled out. There is a system how these operation guidelines were rolled out for COVID vaccination, which was added. Dr. Aimanyu has mentioned about registration process and COVID. And now the COVID has been expanded into UVIN, where routine immunization data are also would be coming through this UVIN. All beneficiaries, all children are going to be registered in this UVIN. So these are all coming up in a big way. Cold chain system is in place. So these can be rolled out. But again, the decision making is through a apex group. And who takes into account everything? Thank you. Over.
Thank you so much, Dr. Prasanta. Dr. Arindam, you wanted to kind of go a little bit more in detail about certain vaccines, but in the lack of time, we don't have that much luxury today. But I'm sure we will be able to do it in some of our next program. Maybe we are more focused on that. But let me try to understand one aspect from you, that when we as I tried to ask for the cost benefit kind of dynamics in that, but when it comes to public health planning, how do you see that when Mr. Goswami highlighted some of the very important numbers, and you yourself highlighted that the pneumonia itself being one of the major killer, and especially in the age group, in the elderly age group, or with the comorbidities and all that. And I'm sure all that kind of also converts into a burden into healthcare system, and a cost to the the public health exchequer, as well as on the overall economic performance of the country. How do you see that this becoming an important aspect in the decision making process, where you do not look at just on the priority of the today, but also see kind of these kind of steps as an important investment towards not only protecting the population, but also saving the cost which you will be incurring if they are left kind of uncovered, unprotected.
Yeah, I'll just quickly go through the immunization value chain from discovery, development to delivery, and just give some 4 or 5 illustrative points on that, where solutioning is already existing, and this government is actually doing almost everything in its power to do that. First of all, on the the economic analysis and all of that, you need good surveillance data for prioritizing your high risk groups and whom you like to do. And the ILI SARI kind of surveillance platform, ICMR is already strengthening to find out, I mean, which age group is being affected, which pathogen, all of that. And the entire PM of 15th Finance Commission investment in surveillance under Government of India's overall stewardship in collaboration with NCDC and ICMR will actually help us in zeroing down on those population groups. Secondly, for the modeling and econometric modeling will help in this decision-making process. The Government of India very recently has established a National Disease Modeling Center at IIT Bombay. And they have brought in almost a dozen institutions in collaboration who will be working with all the domestic researchers and actually produce all kinds of necessary modeling estimates for both disease burden, economic impact, and everything to steer this policy and programmatic decisions for the Government of India. This is all in-country capacity. Let me go to the little bit of vaccine development side. This elderly group, which is one of the highest risk group with comorbidity, they suffer from immunosenescence or immune incompetence or immune senility. So the vaccines are not that much effective, so to say. So there are many kind of new interesting technologies are coming up, which we are also supporting globally and also in the country. One interesting fact I just like to mention, BCG vaccine, which is a very old vaccine used for prevention of TB, childhood TB and miliary tuberculosis, has many non-specific effects. And it has been proven for bladder cancer, for reducing leishmania burden, for malaria. And this is exciting for yellow fever, for varicella. Anyway, I just like to highlight very recent, yesterday, the Government of India has issued a circular to the states to asking their willingness to participate in an implementation research for adult vaccination with BCG to reduce actually TB burden to further the TB elimination goal. I think this is a remarkable step which has happened in collaboration with the, the implementing arm, the immunization division, the central TB division, and ICMR. And they are doing it in a very intelligent clinical trial mode, cluster randomized trial. So I'm just saying, the country is progressing through very evidence-informed way, and that's a very thing. The other point I just like to mention, just two more, give me one sentence. Yeah. One is this: when you reach these high-risk groups, elderly, they are not mobile. You need to base on doorstep delivery. So you need to bring in, say, drones. You probably need to bring in, passive cold chains with longer hold life. And Department of Biotechnology and ICMR both are engaged in very interesting research, and then they already pioneered drone delivery of vaccines. And Black Frog is one startup is coming up with a passive technology which is won an award, and they are actually distributing vaccines even in Africa. All people are talking about digital infrastructure. Just think of an interoperable system when all systems come in one together, along with the digital payment system, along with PMJY insurance system. I think some of your economic and financial barriers can also be overcome. ESI, by the way, is the largest employee state insurance in the world and has probably enough resources to cover some of the most essential vaccines for the adults, at least for their insured patients. I will stop here. Thank you.
Thank you so much, Dr. Arindam. And I'm sure, as you are saying that we may require drone, we have used from pony to drone to, everything in our COVID vaccination, kind of movement. A quick one, Sarajji, I know I am not doing justice with you because you hold the forte on that. I think the overall piece of adult immunization can be given a boost only on the basis of a heightened awareness. People are not considering or not aware about the benefits, about even the availability of many of those vaccines. And the recommendations are also not that consistent from healthcare providers or, so on and so forth. How do you see kind of building the uptake, increasing the demand for these vaccines, and that will automatically start, showing certain statistics and results, and I think push for the government also for the policy. How do you see awareness becoming a tool to achieve that?
Thank you. I make two comments. One very important point, since you spoke about costs and cost effectiveness. If you look at just the Ayushman Bharat program, you have, and again, please excuse me that I will only give pneumonia references because that's the data that I have. Arguably, it's the lowest price healthcare package anywhere in the country, right? That's the whole construct of that program. And you have a package for pneumonia for 40,000 rupees. Now, when you look at that from the perspective of 1 in every 3 of the patients who will come in and avail that package once, will come in and avail it again within 1 year. 40% of those will do it twice in the year. In that construct, if you look at introducing a one-time vaccination, that is the readmission, the recurrence, and the cost that you're going to avoid, right?
Yeah.
So our data suggests that 54% reduction in hospitalization, 57% reduction in costs is what you can achieve with the one-time vaccination, just for this group which has already got infected once. So yeah, there is enough and more data to say and prove that it is a cost-effective intervention. To your point on awareness, you're absolutely right. And a lot of panelists spoke about this. Even for COVID, there's so much awareness, but then the propensity to go and get the booster really dropped. And therefore, you need to keep, that level of awareness, the immediacy of action, the benefit of doing this, you have to keep it top of mind. The private sector and not-for-profit sector can play a very important role here. It should not just be left to the government to publish advertisements and campaigns and radio and all of that. I think the private and not-for-profit sector have to be able to step in and partner. The only challenge there is, and it's not for all diseases, but for a few, is this wonderful thing called the Drugs and Magic Remedies Act of the year 1954. In that year, it was determined, and rightly so, that there is a list of diseases which cannot be prevented, which cannot be cured, and therefore anybody who says that they can be prevented, is not going with science. And hence, any communication to say for the vaccine preventable diseases in that list, any communication from the private sector or not for profit to say this disease is vaccine preventable, go ask your physician today, was not allowed. Now, a lot of time has passed since 1954 to today. Two important diseases. Again, I do speak of pneumonia, but then also cervical cancer. Both of them are in that list, in that annexure of DMRA. So today, even if the private sector or not-for-profit want to go out and raise awareness through campaigns, I'm not talking about brand of vaccine at all. Nobody is going to violate the direct-to-consumer. That is very clear. But if I'm not able to go and say, pneumonia is a dangerous disease or cervical cancer is a dangerous disease, a potentially fatal disease, it can be prevented through vaccination, go ask your physician on whether vaccination is right for you. I can't do that today. But if you are able to exercise certain exemptions in that act, I know the changing the act is a long-term process, then you will be able to enlist the resources, the capacities of the private and not-for-profit sector to do more of what the government is already doing. So I think those pathways need to be opened up, and then I'm sure there will be enough, communication out there and awareness out there to at least take some people to the vaccination center.
Thank you so much, Mr. Goswami. Absolutely an important point, I believe, and must be looked into. Mr. Vishwanath, a quick one, maybe 20 seconds, because many of the speakers are waiting and I need to close it. Sorry.
No. I think the last bit for me is, I think it's a very important topic. As a country, we are moving forward, and I think it requires significant amount of government and private partnership. We are the largest women's health care company in India. So for us, very clearly, women and pregnant women are one of the focus areas, and we would like to partner more and more with the government in how we address not just the most vulnerable population, but also the future of India, because that vaccination during the pregnancy time actually impacts the child, the unborn child, and the future of India. So I think I would just want to end with that.
Thank you so much. Manu, would you like to add something? Very, very quick.
No, I think thanks so much. I think previous speakers have covered everything in line with that.
Thank you so much to all our speakers, and for the sake of time, and as we are already kind of eating into 10 minutes of our the subsequent session, I would skip any kind of conclusion, because all our speakers have covered the topic very well.